My name is Jose Prieto and I'm presenting this case called Beyond the Kidneys Lupus Nephritis with late dermatologic presentation. Systemic lupus erythematosus is a chronic multisystem autoimmune disease characterized by the production of pathogenic autoantibodies and immune complex deposition, leading to inflammation and tissue damage. Lupus nephritis, which occurs in approximately 40 to 60% of patients with SLE, is a major cause of morbidity and mortality in this population. Lupus nephritis results from immune complex deposition in the glomeruli, leading to varied degrees of glomerular inflammation, proteinuria, and progressive renal dysfunction. The histopathologic classification by the International Society of Nephrology is critical for guiding therapeutic decisions and predicting prognosis. In parallel, cutaneous involvement is one of the most visible and diagnostically useful features of SLE, affecting approximately 70 to 85% of patients. SLE specific skin diseases are categorized into acute cutaneous lupus erythematosus, subacute cutaneous lupus erythematosus, and chronic cutaneous lupus erythematosus. These manifestations can appear at any stage of the disease and may coincide with systemic disease activity. Common late skin manifestations include malar rash, discoid lesions, and photosensitivity. These dermatologic signs often correlate with systemic disease activity and may precede internal organ involvement, including the kidneys. We present a 61-year-old woman with a history of Sjogren's syndrome, antiphospholipid antibody syndrome, and type 2 diabetes who presented with a 2-month history of unintentional weight loss, constitutional symptoms, and non-specific gastrointestinal complaints. Laboratory evaluation, as we can see in Table 1, reveals severe normocytic anemia and Stage 3 non-oliguric acute kidney injury with metabolic acidosis and proteinuria. Extensive workup ruled out infectious and neoplastic causes, while serologic findings including positive ANA, SSA, SSB, and hypocomplementemia, along with renal biopsy findings of immune complex mediated glomerulonephritis, confirmed the diagnosis of lupus nephritis. The presence of lymphadenopathy and pancytopenia raised the concern for myelodysplastic syndrome, for which the first-line treatment with mycophenolate was not initiated at the beginning. Notably, by day 3 of hospitalization, the patient developed a progressive maculopapular rash, as we can see in Figure 1, involving the extremities, trunk, face, and sparing the nasolabial folds, highly suggestive of acute cutaneous lupus erythematosus. Skin biopsy confirmed interface dermatitis consistent with lupus erythematosus. The development of cutaneous manifestations at this stage of systemic disease is rare and may indicate evolving autoimmunity or a flare. Management of this patient included initiation of hemodialysis, high-dose steroids, rituximab, hydroxychloroquine dose was increased to 300 milligrams, and posteriorly the patient was transitioned to mycophenolate for long-term immunosuppression after bone marrow biopsy was negative for myelodysplastic syndrome. This case describes an atypical and diagnostically complex presentation of severe lupus nephritis. Although cutaneous manifestations typically precede or accompany SLE diagnosis, their appearance after renal involvement, as in this case, is less common and suggests heightened systemic activity. Here, the skin lesions coincided with pancytopenia and worsening renal function, supporting an active lupus flare. Management involved a multidisciplinary approach and organ target therapy. The patient was initially treated with cyclophosphamide due to hematologic concerns, but transitioned to a regimen of mycophenolate, rituximab, along with steroids, in line with KDIGO and ACR guidelines for proliferative lupus nephritis. A response to immunosuppressive therapy confirmed the autoimmune etiology. This case underscores the prognostic value of late cutaneous signs in lupus nephritis and the importance of early aggressive and comprehensive management in multisystem disease. In conclusion, late onset cutaneous lupus can be a clinical marker of active systemic disease, especially in severe lupus nephritis. The temporal link between skin lesions and renal deterioration, along with biopsy confirmation, highlights the diagnostic value of cutaneous findings in disease flare. The patient responded well to immunosuppressive therapy consistent with KDIGO and ACR guidelines for lupus nephritis management. The case emphasizes the importance of individualized organ target treatment in SLE with multi-organ involvement. Coexisting autoimmune syndromes add to diagnostic complexity, requiring broad differential consideration. And finally, timely recognition, comprehensive diagnostic workup, and multidisciplinary collaboration were essential for clinical stabilization and ongoing management. Thank you.